I'm Mary Jo Murphy, and this is the IANS Patient Seminar Series. Nobody warned us either, sexual toxicity in men after chemoradiation. It's the follow-up to the one we did with women a few months ago. We have three amazing speakers today, Dr. Yin-Min Hu, Dr. Christian Nelson, and Richard Goldman. So I will let them introduce themselves.
Great.
Richard, go ahead. You can go first.
I'll go first. Hi. Welcome, everybody. My name is Richard, and I live in San Francisco. And I've been sexually active since I was in my early teens. I'm gay. And in 1974, I was diagnosed and treated for anal warts. They were burned off and nobody ever thought about them again. And I was also infected with HIV and developed AIDS. And at the same time, what was thought to be hemorrhoids initially developed an infection, and I went in for surgery to have the anal or rectal abscess drained, and turned out to be a tumor, and it was squamous cell anal cancer. And that was in 1990. So, which is 33 years ago now. I was treated with chemoradiation, and at the time, the radiation then was more wider field than it is now, which is more narrow focused, and my pelvis was radiated on top of the surgery that I'd had. So I healed, and the cancer was cured. And what I like to say now is that, and I've said for a while, everything works, just not like it used to. So after I finished treatment in early 1990, I noticed I was having spontaneous erections that were painful from radiation burns and nerve damage. And sometimes they would last for hours. And soaking in a bathtub was comfortable and it actually felt great. And one day I thought, well, what if I masturbated, and would that maybe relieve the erection? And I did, and I was able to orgasm and ejaculate. And that was the first time I had done that since way, way before treatment. It made me cry. I felt like I was alive again. And I went to the radiation doctors and told them what I had done and what had happened. And they said, oh, we didn't think that you would have any sexual function at all, which they never told me. And so I was furious, and I wondered what else they didn't tell me. But what they did tell me was that my prostate would be scarred and that I'd probably be sterile. And that was as much sexual information as I got from the doctors around side effects, sexual side effects. So what I'll tell you now is that I was never hugely into anal sex. I enjoyed on occasion with a partner who I trusted and I felt intimate and trusting with, but it was not the only way that I enjoyed sex. I also enjoyed penis stimulation and orgasm. But now it's impossible to have any anal play at all. That area around my anus and underneath my anus towards the scrotum is very sensitive, and it's always been very sensitive, and it's always been an erotic area to me, but the area around the anus now is too sensitive, and it hurts, and it's painful, and that part of sex has been lost to me. An orgasm, which contracts the anal muscles and the pelvic floor muscles, is also painful now. So it's been hard to find a partner that I feel safe and comfortable with enough to trust and actually let someone touch me down there, because the areas have been traumatized and hugely traumatized by the treatment. And I feel traumatized emotionally and physically, and I don't often feel sexy or attractive. And then there's the GI side effects from radiation treatment, and I never know if I'm going to fart, whether the fart is just a fart or if it's a piece of stool that's going to come out. And that certainly doesn't make me feel sexy either. So I have had partners and it's been challenging. And more recently, I've had more complications and more discomfort around my anus and rectum. I now have a prolapse of my rectum and it's painful and very uncomfortable. And it's definitely not something I feel I can share or be intimate in a relationship with anyone while I'm dealing with. And also my libido is pretty much gone these days. So I don't have a lot of answers. I don't have any advice. I only have my personal experience really with anal cancer treatment and the gift that keeps on giving, which is radiation. And I think it's important to talk about the trauma and the discomfort, and also to talk about sex and to have sex again if possible, and how to enjoy the pleasure of one's body, and also how to possibly grieve the loss of what we may have lost from the treatment. So I guess for me, that loss is a trade-off for surviving and being alive. So that's me.
Thanks, Richard. Dr. Yin, would you like, maybe you two can just introduce yourself and then we can do our memory and then we can start with your presentations.
Sure, I think I'll start. Welcome everyone. My name is Yin Hugh. I'm a sexual health physician. I'm based at Perth, Australia. I work at Royal Perth Hospital. I have special interest in men's health, and I'll be touching on certain sexual dysfunction topics this morning. I'm also a clinician that performs HRA, so sort of am in tune with anal cancer screening. And I thank IANS for inviting me to give this talk.
Yeah, so my name is Chris Nelson. I'm a psychologist. I'm at Sloan Kettering Cancer Center. I work a lot with men after cancer treatments around the issues of sexual functioning or sexual dysfunction. In cancer, you know, a lot of that happens around men with prostate cancer, but I'm quite happy to come and talk about kind of other types of cancer treatment, specifically anal cancer, and the you know, kind of psychological aspects of it, and kind of my thoughts, my suggestions on ways to help address some of the sexual difficulties after cancer treatment.
Thank you. Okay, Audra or Chris, the next slide. Audra.
I can pull up here. I'm just
Okay, that's wonderful. Thank you.
There you go. How's that?
So that's lovely. So we are honoring Dr. Eric Gantz's sister-in-law, Susan J. Gantz, who was had anal cancer and died in 2012. Okay. Are you going first, Dr. Yin?
Yes, so I'm going to share my screen.
Good.
Can everyone see that?
Yeah, looks good.
Yes.
Okay. Yeah, good. Okay. So I'll just be giving a brief overview or outline on the sexual dysfunction aspects of experiences that men can experience after chemoradiation in anal cancer. And like I said, I'll briefly discuss about the side effects. I'll briefly touch about the baseline health, or the baseline things that people go into before actually embarking on anal cancer treatment, certain aspects of treatment, and what to sort of expect from the treatment itself and potential outcomes and side effects. So in sexual function, we always talk about biopsychosocial model, and I think this is not an unfamiliar concept for most clinicians and patients. There's never one reason or possible reason why sexual dysfunction occurs. So it all depends on the biological side, how we're built, any medical conditions, genetics that certainly can influence how our body function. And then we always have to couple it with the psychological aspects of sexual function itself, the expectations, how we view ourselves, the self-esteem, and also how relationship happens, and that's the interpersonal aspects of things, and how we are generally brought up and how we perceive sex as a form of education from our upbringing and everything. And all this 4 domains sort of encompasses how our experience with sex is and how it can potentially affect sexual function. And I think this is important because what I'm highlighting here is any interventions or management certainly requires a multidisciplinary approach to help and manage sexual dysfunction problems. And it's just not one clinician or one person that can sort of contribute to any sort of sexual dysfunction. And I'm sure Dr. Nelson will sort of elaborate more on the psychology aspects of the management and also how it influences our thoughts on sexual function. But this is certainly an important model because from a patient perspective point of view, I guess if you're expecting to sort of just see one clinician to solve your problems, then I think it's best to sort of have a wider approach. And from a clinician point of view, it's also important to understand who are the other specialists or specialty people that can help the patient to manage the sexual dysfunction. So just like what Richard has mentioned earlier, chemoradiation certainly can cause a lot of side effects, mainly because of the anatomy of things. So from a gastrointestinal and urological point, some of these side effects are sort of now more known, especially when you have pelvic radiation. So this list is not limited. These are just some of the main highlights of some of the side effects that certainly can occur after chemoradiation. So pain being one of them, and the percentage roughly occurs in about 27% of patients. Now, I got all this data mainly from accumulation of all the available journals and data that has people have looked at over many years. And it's important to know that the data are building up nowadays, but it has been a bit sketchy and has been a bit lacking from the side effects from a sexual function point of view and also from chemoradiation. But certainly there's more data happening now, and people are beginning to understand and report that chemoradiation can cause a lot of problems. Altered sensation being one of them, and radiation dermatitis, mainly the skin around your pelvic region, your genitals, your perineum just doesn't feel right or might be highly inflamed either immediately or much later down the line after radiation. And this can certainly have an impact on how function, not just sexual function, but function, bowel function, urinary function, and how it can affect quality of life of patients who have gone through radiation. Diarrhea is reported in most case series occurring as high as 45%, and bowel changes in terms of fecal incontinence or maybe urgency, fairly high, and it's a huge range here from 7 to 78% of patients might experience that. Just like Richard said, the flatulence in about 55%, where it's unpredictable and sometimes it's uncontrollable. There's also lower urinary tract sort of symptoms in terms of urgency, in terms of painful during urination, that can be problematic. No doubt, no one reports about energy levels, but obviously radiation itself can take a toll on how we feel and can affect energy levels. And if you're not fully energetic and you feel tired, alongside with some of these side effects, then the quality of life certainly will be much less before radiation. And the prevalence of all this happening, it's fairly high. I mean, it's 79%. So you can imagine a lot of patients probably will experience one or more of some of these side effects from a bowel perspective or from a bladder perspective point of view. And I haven't even touched the sexual dysfunction yet. So moving on to the sexual function of chemoradiation, it's been reported it can cause sexual dysfunction as high as 90%. So without doubt, you will be expected to have some form of side effects from the radiation itself. The problem we have as clinicians is we have very little data to document exactly what is the problem, what sort of sexual dysfunction, the duration, and how generally affects the patients. And especially from the men's perspective, we now have a lot of evidence from the female perspective and from the patient seminar last year. It's evident that we know how to deal with a lot of things. But from a sexual dysfunction point of view, in a men's perspective, in anal cancer, the data is very sketchy and there's very little data out there. So from a clinician's point of view, it's not, and it won't be surprising that the communication or the education prior to sort of radiation and side effects might not be discussed as the data is certainly lacking. But what we do know is when it comes to sexual function of men, the erections, orgasm, ejaculation will be the main sort of topics or function that can be affected. So from a sexual point of view, erectile dysfunction likely will be noticed. Problems with orgasm, problems with ejaculation probably will be experienced at the same time. I mentioned libido there mainly because I think this is important for men, because if you don't feel like having sex, then nothing is going to function. And libido indirectly will be affected from multiple causes, which I'll touch on later. And because of that, then that will certainly generate performance anxiety. And with performance anxiety, if you can remember the psychosocial model, which I mentioned earlier, the sexual function certainly will not be functioning properly. I thought I'd just sort of mention about penile function to allow people to have an understanding on how the penis works in a way, and how that can certainly influence some of the sexual function. So penile function requires two main things: blood supply to the penis and also the nerve supply. And if either of these factors are affected or disrupted, then you're going to have a decline in penile function, which indirectly will then affect your orgasm or even ejaculation. And no doubt the blood supply and nerve supply also will supply the organs that's responsible for orgasm and ejaculation. But on top of that, penile function will also be affected by underlying comorbidities or health problems. So HIV being a huge part of it, as we all know, HIV is very relevant because it can affect multi-organs. And even in the absence of cancer, you might notice sexual dysfunction occurring in the context of HIV. And if you have diabetes on top of that, then it will certainly make things worse. Cardiovascular risk factors, as the aging population starts to live longer, they certainly will have issues with heart health, and that certainly, without a doubt, will affect sexual function. It's important to know that sometimes you notice sexual function being affected, and that could be a marker that there's something underlying happening. No doubt, lifestyle changes, smoking, alcohol, sugar control, diet, all this will affect sexual function. So if you already have problems like this, even before you start treatment for anal cancer, then you can imagine some of these underlying risk factors will make recovery or even the function worse. And there's no guarantee that even after the anal cancer treatment that the function will recover, but that's the hope. So if you have less comorbidities, then the chances of recovery probably will be slightly higher. And I think this is highly important because sometimes we forget about the underlying health issues that is also experienced by some of our patients who undergo anal cancer treatment. This is my attempt at drawing, and this is what I normally do with my patients. I thought we'd just draw, and this is what I've done. It's just an overview of where things are. So if you can see, that's the spine, the prostate, the penis, the testis, and these are just the nerves that sort of is communicated from the spine. But this is roughly where the location is, the rectum and the anus, all right? So this is the area where the radiation oncologists will be targeting. This is obviously not up to scale, and this is just an illustration on how or where things are affected. So you can imagine all this whole area here can be affected, including your prostate, your testis, your penis, your nerve supply, because ultimately the treatment area will be around here. And I just highlighted some of the nerves that actually contribute to the sexual function, the sympathetic, parasympathetic nerves. These are involuntary nerves. You have sensory and motor nerves. So, if any of these nerves are affected, either partially or completely, then certainly the sexual function will decrease both from an erection point of view, orgasm, and ejaculation. And we do know it's relevant because a lot of studies from the pelvic region are based from prostate cancer. And we have a lot of data from prostate cancer to know how things function. And it's not any dissimilar from anal cancer in terms of the nerve supply. Once again, I just wanted to highlight the sexual dysfunction that can occur. And so just broke it down a bit more. So in terms of problems that can potentially be experienced by patients from an erection point of view, it can be a difficulty achieving an erection. And even if you do achieve an erection, you might notice the penile hardness to not be that good. We grade sometimes penile hardness according to a scale, 4 being the maximum. So any penile hardness that's sitting at 2 out of 4, it potentially means that you're unable to actually have penetrative sex because the penis is just not hard enough. And even if the penis is hard enough, you can initiate sex. Sometimes difficulty maintaining an erection can be an issue. And then moving on to orgasm, you might be able to experience orgasm, but the feeling is different and the intensity of orgasm is different. So it's what we call a muted orgasm, or sometimes you don't achieve an orgasm at all. A lot of patients sometimes do feel I'm nearly there, but I just need that extra to achieve the orgasm. It doesn't happen. So the orgasm can be affected in this way. And that can be extremely frustrating because if you're not ultimately achieving orgasm, you're not going to derive the pleasure from sexual intercourse itself. And then when it comes to ejaculation, there's a possibility orgasm and ejaculation sort of go hand in hand. So sometimes you can have a delayed ejaculation. It takes you 20, 15, or even longer minutes to achieve an ejaculation. And that can be extremely frustrating. Premature ejaculation, probably not so relevant, but it can happen. And if someone who normally has a normal ejaculation time of about 5-6 minutes, and then suddenly they ejaculate under 1 minute, that certainly can be a distressing factor for people. And one of the other things is people notice there's no ejaculation. All right, well, what's been happening? And obviously in men, if you don't experience an ejaculation, the first thing that comes into your mind is there's something certainly not right, and I don't feel as masculine because there's no ejaculate. The ejaculate sometimes happens, it just is going in the wrong direction. So that's retrograde. It's just going back into the bladder, and you're just not noticing it. And like I said, you can't talk about sexual function without mentioning about libido. Libido is just a general term talking about desire and arousal. And if you don't feel desire for whatever reason, if you just don't have that self-esteem to actually engage in sex, then sexual function is going to be certainly affected. The point I tell my patients is the penis is such a thing that if you don't use it, you start to lose it. And just like anything else, if you have low libido, then you're not going to be able to achieve an erection, let alone have an orgasm or ejaculation. And libido itself is certainly a complex thing that we are still trying to understand. And once again, it's certainly a lot of issues can be involved with libido. One of the things I highlighted there is pain. Now, I mentioned about pain being one of the side effects of the treatment, and pain can be anywhere, and it can originate from either the radiation itself or the nerves dysfunction, or certain organs being scarred from the radiation. So if you have pain, then that will certainly drop your libido, and that will affect sexual function. Now, we have treatments to sort of treat erectile dysfunction, and that certainly is not an issue when it comes to erectile function. And the usage of some of the PD5 inhibitors, which commonly known as Viagra or Cialis, has been in the market for over 30 years, and it's been proven to be pretty effective to help with the functioning of the penis. If that fails, then you have other methods like a vacuum device or penile injections to help achieve that function again. And the last resort is a potential penile implant, which I think people are a bit more in tune nowadays to have that done so that they can achieve the penile function. And like I said, all these data are derived mainly from prostate cancer patients, which is not dissimilar to what will be experienced by anal cancer patients. I thought I'd just mention briefly about libido itself, because libido, just like anything else, can be affected from sexual function change. As a baseline before entering treatment for anal cancer, if you are gay and if your preference is the receptive person, after treatment, just like what Richard has mentioned, the pain, the discomfort, that might change your sexual practices. So sexual preference might then change, and your role in sex itself will change. That certainly can affect your libido, because this is not what you normally enjoy, and now you can't enjoy something that you have been enjoying. Libido itself, obviously, if you have ongoing side effects, especially from a bowel point of view, or even from an erection point of view, that will certainly drop things that will affect your self-esteem, and that will certainly affect your quality of life. Now, some of the treatment, especially radiation, does not mention about hormones, but as you can see from the previous diagram I've put on, your testis is quite near all these areas. Although treatment nowadays are much better targeted at the specific location of where the cancer is, without doubt, when it comes to radiation, there's still a bit of fragments of radiation that can potentially affect your testes. And when it comes to hormones, testosterone is one of the things that potentially can be affected and probably should be thought of if you are experiencing a low libido, low energy levels, to ensure that the testosterone values have not dropped significantly. I don't think anyone actually checks testosterone before they go into any treatment. Perhaps that might be something that could be looked into or discussed based on symptoms, obviously. Where I practice, we don't routinely do that. But obviously, if the patient is reporting certain symptoms consistent with testosterone deficiency, I think that certainly can be looked into, probably as a baseline before you have your treatment, and then something that can be looked into again after treatment to see if there's any changes or drop, and perhaps that can be addressed if there is evidence of testosterone deficiency. And once again, libido, depending whether you're in a relationship or not, issues like self-esteem, guilt, and anger can certainly crop up, which can reflect and affect libido, which I'm sure Dr. Nelson, after this, will probably touch on and give you pointers on how to deal with that. This is my last slide, and I thought just giving you the overview on how to potentially prepare yourself. I mean, there's no right preparation, but I guess having the information and expectation on what can potentially happen can prepare you in one way to manage some of these side effects a bit better. Because like what Richard said, if you're not told about some of the side effects, then certainly everything will be a shock after your treatment. As much as survival is the main thing that everyone thinks about, but the quality of life after surviving is highly important. And I think patients, before actually embarking on any treatment, should at least have those information to process and digest to see whether they actually feel whether certain aspects of their treatment can be discussed, or how certain things can be minimized to get the best outcome so that their quality of life won't be compromised. Obviously, understanding your baseline function, if you're already going into treatment, already having problems with your erections, then that is where your baseline is. So the expectations of things improving more than that is certainly unrealistic. But it's also the time frame. If you are to expect erectile dysfunction to occur, is there any possibility that it can recover, and what's the solid time frame? Now, we know nerve can potentially regenerate and nerve can heal, and the time frame, it takes months. So I always tell patients when it comes to nerve damage that it can take up until about 2 years for things to recover, and even then they don't, or they might not recover fully. So at least you have an idea on where the time frame and expectations can then be managed a bit better. Once again, I highlight lifestyle and comorbidities. It's always important to sort of optimize your health prior to any sort of treatment in terms of smoking, alcohol, weight loss, and exercise. So certainly we know through different type of cancers, if you actually highlight lifestyle changes, then your outcome probably will be a bit better. I sort of mentioned possible penile rehabilitation. For those people who are not familiar with this concept, penile rehabilitation is basically just interventions that can be used to actually maintain penile health, and that's the usage of Viagra or Cialis even before radiation treatment, mainly to encourage blood flow and to optimize the penile health. Because once you start radiation and chemo radiation, there'll be a period where your penile function will drop, or you will be sexually inactive. And I think giving your penis the ability to go into that treatment at the optimized rate is certainly possible. And the penile rehabilitation, once again, like I say, these are data derived from prostate cancer patients, which are not similar. I think in the interest of time with that, I will just stop here, and I will let Dr. Nelson do his talk. Thank you.
Yeah, thanks, Dr. Hu. Really, yeah, really excellent information. Great talk, and it's nice. It's nice when I join these things and learn, and so it was nice. I learned a lot for your presentation. Thank you. And so, so again, my name is Chris Nelson. I'm a clinical psychologist. I'm at Sloan Kettering Cancer Center, and nice to be here today to talk with you about some of these issues and concerns. And in terms of my presentations, there's no financial disclosures that I need to talk about. And so, Dr. Hu talked about the common sexual problems that potentially can occur after treatment for anal cancer. And so, he highlighted these already, but erectile dysfunction, he talked about difficulty reaching a orgasm. Dry orgasm might not necessarily be something you see a lot after anal cancer, but potentially there, pain and orgasm, and potentially penile length alterations, but and loss of sexual desire. But I think Dr. Hu summarized these very nicely. One of the things that we see a lot after cancer treatments and also anal cancer treatments is really what's top on the list is erectile dysfunction. And when I talk, a lot of my talk will be focused on erectile dysfunction, but I'm going to weave in things like difficulty with orgasm, low sexual desire, maybe even pain at orgasm, because the concepts and how it impacts kind of a man and potentially a relationship are very similar. And so, one of the take-home messages should be from all of this is that really every man's masculinity is impacted. Right? It's not as if some men get away scot-free and other men don't, but masculinity is impacted, whether it's difficulty with erections, whether it's related to things like a muted orgasm, lower sexual desire. And even as Richard talked about his experience, the notion about, the area around the anus kind of, and just the pain and discomfort, even in that area, touching that area can impact masculinity. And so really the question about this is, so what? How much do we care about this and how much should we care about this? Because here's what patients say that others tell them about difficulty with sexual functioning following cancer treatments. And so here's what I hear from patients that they're told, and they're told things like, well, at your age, does it really matter? If you look at the average age of anal cancer, I think it's in the 60s. And so they might say, well, in your 50s and 60s, maybe you're just packing it in. Does sexual functioning really matter to you? Sometimes there's the comment, well, you shouldn't be upset your cancer is gone. And you're clearly happy the cancer is gone, but you're also, have to live with the side effects, and it can be very upsetting. And then kind of one that, that you'll just get used to it, right? Is such a kind of way to just not validate kind of a man's experience after these treatments, as if this is something that you should get used to or could get used to. And so ultimately what we know now from the research is that sexual functioning problems actually impact men a lot. And it turns out that things like erections and difficulty with erections, it turns out men really like their erections. And they're important for men in a sense of masculinity. Erections for a man go to core what it is to be a man. And we know from the research that erectile dysfunction is associated with depression and depressive symptoms. And some studies actually indicate that as many as 50% of men who have difficulty with erections warrant actually an evaluation for depression. So they're exhibiting enough depressive symptoms to really be evaluated. Other things related to erectile dysfunctions, the concerns about them just don't go away over time. And, our research shows that after these cancer treatments, men's concern about their erections goes up because they now have difficulty with erections. And that concern or that bother related to the erectile dysfunction stays consistent out to 2 years after treatment. That's as long as we measured it. I'm sure it stays consistent after that. What's interesting in this research is that oftentimes it's not just talking about men's disappointment about what's happening in the bedroom, but it talks about quality of life and it talks about kind of general happiness in life. And many men will report when they have difficulty with erections or difficulties with other sexual functioning, that it impacts them not only in the bedroom, but they just feel less confident. It impacts their general happiness in life. It kind of permeates throughout other aspects of their life. And then this can create significant relationship difficulties. And I'll talk a little bit more about that. Now, the good news is for something like erectile dysfunction, Dr. Hugh talked about, we can help. There's actually really good treatments. And he talked about these, the pills, the PD5 inhibitors, the Cialis, the Viagras. He talked about penile injections, vacuum devices. Muse is something, it's medication similar that's what's used in the injections. And there's an implant. And, he talked about some of these, so I'm just going to skip over it. So we have these good treatments for this, but one thing to keep in mind, especially kind of as you're thinking about this and going through the journey, is that oftentimes what happens is that when men have difficulty with sexual functioning, difficulty with erections or other difficulties, again, whether it's difficulties with orgasm or whether it's libido or whether it's just kind of, again, as Richard had talked about, his concerns about the bowel side effects and what happens in a sexual situation in terms of bowel side effects. All these things can lead to avoidance. And ultimately, what happens is that men tend to avoid and even tend to start treatments or drop out of treatments and engaging in sexual situations. And here's just some information on that. And so for the PD5, so PD5s are those pills, the Viagra, Levitra, Cialis, 50% of users don't renew their prescriptions. And those who use penile injections to help with erections, 50% drop out. I've used some other data just in terms of self-report use of penile injections, and only 60% continue after 4 months, and only 33% suggest at the rate of rehabilitation, which Dr. Hugh just touched on in terms of penile rehabilitation. If you do a more objective count, how often are men using injections? Really less than once a week, and only 10% at the rate of rehabilitation if you actually use a more objective measure such as counting syringe use. And so we know it can actually be very difficult. And so what we've done is we wanted to really meet with and talk to men after these cancer treatments and talk about kind of, what happens and why is it difficult to use these treatments? Why is it difficult to engage in sexual relations again? And in talking with these men, here's what they said. Basically, they've outlined a cycle of frustration and avoidance related to these. And so first, it's a sense of disappointment and shame related to erectile dysfunction or DD, the sense of not being a man. This distress and depression, this leads to distress and depressive symptoms, but then it's a sense of fear and anxiety of entering into a sexual situation when things like not having a firm erection. They talk about treatments as a turnoff. The whole process is humiliating. Again, this is focused on erections, but think too, if there's bowel side effects, think if you have difficulty with libido, other aspects, this is going to impact a sense of fear, anxiety, entering a sexual situation. This fear tends to lead to avoidance, the loss of value life activity, which just increases the distress and frustration. And so ultimately, this is a way to think about this cycle of avoidance, specifically with the idea of erectile dysfunction and the need to use ED treatments. It starts with a problem. There's some negative thoughts like, I'm not a man, I'll not be able to finish, using treatments is unnatural. This leads to an emotional response, increased fear, anxiety of a sexual situation, leads to avoidance. Then what happens, this avoidance, it's really short-term relief. When you avoid that day, that night, you feel good about it, or you feel good because you're not anxious anymore, but ultimately it leads to kind of an outcome of life restriction. And so one of the things I want to talk about is this notion, so this is a stereotype, right? And I just want to focus on here kind of on the top of men, and really kind of men, the stereotype is men are always in the opposition. They're always ready to go. Like ED treatments, let's give them some pills, they'll use them, everything will be fine. But what happens when men have difficulty with erections, other sexual functioning, is that actually they may be permanently in the off position. And even though we have good treatments, they're in that off position. They have a hard time getting started. And one of the things we want to communicate is that it just might be difficult to engage and start engaging in sexual relations again because of the anxiety, because of the fear. And so how do we help men engage in treatments? Well, we think about things like, seeing a psychologist or seeing a sex therapist. And for men, sometimes the notion of therapy isn't all that appealing. So I like to talk about coaching, right? And ultimately, it's about coaching and start with the importance of sexuality and why it's important to you as a man. This notion of acceptance, knowing that there's going to be some anxiety in the short term, right? When you think about approaching a sexual situation using these treatments, there's going to be some initial anxiety, but hopefully what you can do is we call willingness, a willingness to experience that anxiety for the long-term goal of following through. And so then there's kind of, hopefully you can diffuse the anxiety and frustration, really, which is in the notion of hopefully maybe discussing this, or as you engage, some of that fear might dissipate. Discuss barriers and solutions, or think about what those barriers might be to you, and then hopefully a commitment. But ultimately, the way this works out in a cycle, in a framework to help think about engaging in sexual activities, is one to, again, think about why it's important to you. This notion of acceptance, know that you're going to be nervous and anxious as you move into a sexual situation. Know that, okay, I'm going to be nervous if I think about using these ED treatments tonight. That's okay, that's part of the process. There's a concept of willingness, which is willingness to experience the anxiety, but move forward and push forward with those treatments anyway. So there's this concept of diffusion, kind of maybe some self-talk, which is no pain, no gain, using humor to normalize some of these experiences, and then engage in hopefully some sexual relations, which hopefully then leads to an increase in intimacy and then a commitment. But ultimately, this notion of avoidance might be very, very, very germane, and might really impact you as you think about kind of how to pursue and maintaining or starting up a sexual relationship again after these treatments. And so some other thoughts in terms of maintaining a sexual relationship. The impact of sexual dysfunction on relationships. So oftentimes in terms of this avoidance, what happens is that men can withdraw from their partner if they have difficulty with erections. And I've talked with men enough to know that they say, well, if I'm not confident in my erection, ultimately what happens is I don't want to get things started because I know I can't finish. And so they may fear that they can't perform, or potentially kind of, there may be some relationship distress there. And so oftentimes what happens if men have difficulty either with erections or other sexual dysfunction, they'll withdraw from their partner. Another aspect of that is the partner may fear setting the patient up for failure, and the partner may also back away. And so oftentimes there's a lack of communication around these types of things, where oftentimes the partners are just on different planes. And so the more you can discuss, bring up these concerns, bring up these fears, the best. In heterosexual relationships, often what happens, there's kind of like a he said, she said, which is just kind of men and women on sexual functioning just maybe on different planes. That is, a man may have difficulty with erections after these cancer treatments. The female partner, again, if it's a heterosexual relationship, the female partner may say, erections aren't such a big deal to me. It's okay. We can do other things in a sexual relationship. And then what happens is the man then actually says, well, wait a minute, erections are very important to me. They aren't important to you, and can cause some distress and anxiety. Other things that potentially can help, strategies to improve. So non-pharmacological strategies, things like sensate focus. And sensate focus is something you can look up, you can Google it to kind of get the stages, but there's basically 3 stages. The first stage is essentially, it's massage with clothes on, clothes off, but not sexual massage. So breast, genital areas are not supposed to be in play. And the focus is an erection, the focus is an orgasm, The focus is coming together and joining and touching in a way that feels comfortable again, without the pressure of how to move forward, whether it's the intercourse or orgasm. The second step of sensate focus is where you continue with massage, where breasts and genital areas are quote unquote in play, but still the focus isn't on erection, the focus isn't on intercourse, the focus is not on orgasm, but just coming together in a relaxed way to experience physical touch again. Sometimes what's helpful is to set time aside for intimate talk and intimate discussions. Diary. We talked about kind of a loss of desire potentially after these treatments. Recording kind of during the day when the desire might be high for you or higher for you might be a good time then to highlight which times it really is helpful to engage in sexual relation. Self-stimulation, exploring kind of what works for you before you enter into a sexual situation with a partner can be helpful. And also things like consultation with a sex therapist, with a psychologist can also be helpful. And, Dr. Hugh talked about the notion of you might need a couple different providers, the sexual medicine professional to help you talk about kind of the treatments to address kind of what's happening physically. And then maybe a sex therapist, a psychologist to talk about how you integrate those treatments, how you use those treatments in a sexual situation, and how you kind of work those out with your partner. Here are some referrals for that. Now, these are specifically kind of US referrals, but the Society of Sex Therapy and Research STAR has a nice referral list of people out in the United States, sex therapists, and also the American Association of Sexuality Educators, Counselors, and Therapists, ASEC, also has a nice list of those sex therapists, psychologists who can help. The American Cancer Society has some good resources as well. It talks about questions about adult males that have about cancer and sex and the adult male and cancer with cancer. And so that may also be a nice resource. And so I'll stop here because that's my last slide. And hopefully we have a few minutes or some time for questions and we can take those.
Okay. Oh, thank you. That was amazing. Richard, come back. Okay. So can you see the questions that are here on the side, or should I read them?
We can, yeah. Mm-hmm.
Okay. I think the question about why physicians or clinicians wait so long, if we could answer that, we wouldn't even have to have this seminar, but that's a good question. And then Helen's questions about going back to or how to deal with getting back to anal intercourse. But go ahead, you can read them.
I was just going to say the interesting question really is this discussion of toys or dilators or dildos to help the anal health or anal tissue after the radiation treatments. And Dr. Hugh, I don't know if you have any thoughts on that or any information on that or. Mm-hmm.
Well, I certainly don't think there's any sort of information or data on that, but certainly the concept is not dissimilar to the female vagina in a way. I guess the only difference is the anal canal, obviously, although it's a pleasure sport, it's slightly a bit different with the vagina, but I can see the understanding on just like exercising any part of your body. So certainly using a dildo to sort of ensure that the strictures or elasticity of the anus is maintained. It's an interesting thought. I don't think anyone probably have actually pursued this, not that I'm aware of. And through my experiences, some of my patients, like say some of these side effects probably just puts them off sex and they don't want anything being up their bum anyway. But I might be wrong. Has obviously long-term wise after a couple of years, then things might need to be revisited. But that's an interesting concept, and I think I don't think there's any data to suggest that that is something that needs to be done or will be helpful. But yeah, it's an interesting concept.
Yeah.
I'm going to add, I want to add that,
Yeah, please. Yeah, go ahead, Richard. Yeah.
that perhaps pelvic floor physical therapists could really, really help in that area in terms of if there are strictures or which is one of the things that happens in scarring in both men and women. The pelvic floor physical therapy can be enormously helpful. So, and they're out there.
And I think the concept of a dildo or a dilator, you know, Dr. Hugh talked about kind of vaginal health, and after cancer treatments, you know, that's certainly been tested for women in vaginal health and have with positive results. But if you like, and as Dr. Hugh suggested, like, I don't think there's any research on it kind of related to the anal tissue. And if you were to do that, I would have a combination of 3 people that you work with. One is a person like Dr. Hugh, a sexual medicine specialist, who will give you, quote unquote, the go ahead from a physical perspective to say that that might be okay. The second person would be, as Richard suggested, like a physical therapist or physiotherapist who specializes in you know, kind of treatments in that area, right? The pelvic floor specialist, and then also someone like me, a psychologist or a sex therapist who has experience using kind of those types of treatments with women, because there's a specific protocol that's used. They start with a smaller dilator and work up to larger dilators. There's a specific method on how they do it. And so really interesting idea, but I would incorporate kind of at least 3 people if you try it to make sure it's appropriate.
This cancer definitely in men and women needs a team.
Mm-hmm.
Somebody, another person asked about did I hear that the radiation affects your prostate also? Is that Dr. Hugh?
I don't think it affects your prostate specifically, so indirectly. Yeah, I think it's mainly the nerves. No doubt, you have to understand that prostate health in men as they age will be a problem. So that's certainly something not to be ignored, and it could be a separate entity on its own.
And also, there was a question that came in earlier about lymphedema in the genital area, and you had answered that to me, but maybe you could answer that again.
Yeah, so if I can try and remember the question, I think the question was there's lymphedema
post treatment,
post chemo.
Yeah.
So without doubt, it's not. My understanding is obviously I'm not a radiation oncologist. My understanding is it can happen. It's not that common, but any sort of effects on radiation and chemotherapy can affect the lymphatic drainage that actually circulates all the fluid back and up our body. If that's not functioning well, then you get pooling of the fluid around your genital regions. Yeah, so certainly that can happen. What can be done about that? I guess in cancer units, they have teams set up to deal with things like this, lymphedema units and things. But certainly things that the patient can do is if it's at the genitals, then sort of compression underwear or support underwear to help ensure that the fluid gets circulated. Sometimes you can do a self-massage to just push the fluid back. And if the edema is too troubling in terms of it affects your urinary function, then there are certainly urinary sheaths or devices that can be put over the penis to help with the urine flow. So I hope that sort of answers the question. But I guess ultimately speaking to the oncologist to see if there's a team that deals with lymphedema, and they normally should have that in most cancer centers.
I wanted to invite Dr. Emma Holliday to come in for just a minute. She was our speaker in the women's sexual toxicity. Can you unmute yourself, Dr. Holliday?
Sure. Hi there.
Hi, and you can put your camera on too. You answered the question about the prostate also, so perhaps you could do that again.
Yeah, no, just, from the technical aspects of the radiation treatment planning, because the back third to half of the prostate is so close to the front wall of the rectum as it transitions into the anal canal, the back portion of the prostate does see the radiation beam. And so there is scar tissue that forms within the prostate gland itself after radiation. So when I'm counseling my patients, but before we undergo the radiation treatments, we definitely talk about that as part of the patient education. That if the part of the prostate turns to scar tissue, it's not going to do its job of making the fluid that contributes to the ejaculate, the fluid that makes up ejaculation. And that's part of what can contribute to less pleasurable or less intense ejaculations, is because there's less fluid that comes out. So I think it is something that's not talked about as much as it should be when counseling folks on what to expect after treatment in terms of sexual side effects.
Thank you.
Yeah.
I just we're getting close to being done. I really don't like to go much beyond because people have time constraints. But I did want to, first of all, say the obvious, that this isn't meant to be medical advice. That I think we have to find some resources in other countries, Dr. Nelson, because clearly, because this is an international organization, I think we need to work on that. And I would encourage you all to watch the seminar on women's sexual health too, if you get a chance, because there were some really interesting things there about the pelvic floor and pelvic physical therapy that I think are analogous to what we're talking about here. And then I would just encourage you to, if you do know men who have been through this treatment who didn't come to this seminar, it's recorded, and I would like you to tell them about it so they can watch it too, because I think it's been amazing. I do feel like we're stepping into some territory that hasn't been stepped into, and I really appreciate Richard coming forth and telling his story. And I mean, Richard didn't tell us that he's an RN and a physician's assistant and all kinds of other things, but but anyway, his presence here was really important, I think. And I am very excited to have had both Dr. Hugh and Dr. Nelson. It's hard to put these things together sometimes, especially since people are all over the world, but you're here and we did it. And please, if you consider joining IANS as a patient, as a patient advocate, then you can have some say in terms of what subjects we bring up. But we try to talk about things that as a survivor myself, I hear people talk about. So I really, really appreciate everybody being here. And I think we'll let you all either start your day or have dinner or go to bed.